Thank you for joining the Palm State podcast today with gerontology expert and medical doctor, Dr. Michael Steinman. Please remember that all of the information provided in this podcast is informational only. Medical advice is at the purview of your medical professionals, so please consult them to make sure you're getting optimal care.
To make sure you don't miss our next conversations, subscribe. We are so happy to have you on our show, Dr. Steinman. Palm State is a brand created to help us all age as independently as possible for as long as possible. And the only way we can do that is if we're informed. It's also easier to do that if we all have the same information and we're operating with similar information together, particularly as the definition of a care team as we get older expands to family members or friends or people that we trust. So we are aiming to bring individuals and the people they love most together, including Ashwini's and my own families, as we go through this journey, bring us all together with the people we love most with information that will help us age well.
Dr. Steinman, welcome. We're very honored to have you with us today.
Great. Thank you for having me.
I'd actually love to start with how you got into the field of geriatric medicine.
Sure. So I kind of got into geriatrics almost by accident. I'm a professor of medicine in the Division of Geriatrics at UCSF and the San Francisco VA. I am the sort of co-director of the UCSF Pepper Center for Aging Research and also co-director of the US Deprescribing Research Network. So when I completed my residency training, which is the training you get after completing medical school, I had took care of course, a lot of older patients, in both the outpatient and in the hospital setting. But I actually had very little exposure to geriatrics as a field because at that point it was much smaller and less well known. But at that point, I was actually interested in research about improving how we take the things we already know what to do about how to improve care and actually how to make them happen in the real world. And through the process of doing that, I ended up sort of getting connected to several geriatricians who had just recently arrived at UCSF, which is my institution. And through approaching them through the research angle, I sort of learned about the clinical field of geriatrics much more in depth than I had before, sort of fell in love with it. And so then in addition to after doing my research, sort of, postdoctoral training, I then went back and I completed my geriatrics clinical training to clinical fellowship. And that's how I landed where I am.
Can you talk a little bit about how geriatrics pulled you into the deprescribing field? And we're all familiar with prescriptions, but a deprescription is not something that I was familiar with until I learned about you and all of your research. So it would be wonderful to walk us through that.
Yeah, so deprescribing is a fairly new term. And basically what it refers to is sort of the proactive approach to either stopping or reducing the dose of medications that are either no longer needed or which are causing more harm than good. So it's a pretty common sense. It's basically sort of right-sizing your medicines. Not too little, but also not too much, where you're taking stuff you don't really need, or that's actually, like I said, causing more harm than good. So deprescribing really puts the focus on the stopping and reducing medications part of that. It doesn't mean that that's the only thing that's important. Of course, it's important to start new medications, which you're not taking, which might be helpful, but it's a way of restoring that balance because traditionally in healthcare and medicine, there's been a focus always on adding. It's easy to add stuff. You go to a doctor, what do? They give you a new medicine, but it's fairly uncommon. You go to the doctor and they take something away, particularly if it's not something that's causing an obvious, immediate problem. And so we're really trying to restore that balance by focusing on the reducing medications element, just to make sure that everyone is ending up on the medications that are actually best suited to their needs and their goals.
I was doing some research. It seems like in 2018, there was a study out of Canada that led to the Empower and the Deprescribe study and movement. But what was really interesting to me in reading up on this and looking up on this is this concept of an intervention by a brochure, right? That's not something that a patient would also be used to. Is like, sitting down with a doctor and getting, here's a checklist or here's a brochure, not a drug, right?
Yeah. Yeah, I mean, it's a really interesting topic. And those are a fabulous series of studies that you referenced that really had a big impact on the field of deprescribing. And the idea for a brochure sort of came out of the observation that deprescribing is really hard. And there's a few reasons for that. First of all, there's this sort of cultural and normative expectation. When you go to the doctor, you will get something positive to do something. You'll get a new drug, you'll get a new prescription, you'll get a new treatment of some kind. And the idea of taking something away, even though many people are concerned about the number of medications they're taking, it has the potential to be perceived in a negative way, like you're taking something away as opposed to adding something positive, even though taking something away might actually help your health. So there's that sort of psychological barrier. There's also just frankly barriers about time. Doctors' visits tend to be rushed, and there's almost always more things to talk about than there's actually time to talk about. And so, as someone who practices myself, I experience this in my own clinic. There's always more things that I would like to get to than I have time to do. And deep prescribing, because it tends not to be the first thing that people identify as a problem when they walk into the doctor's office. And we're really not incentivized to think about it as sort of the top of mind. It's something, even if it's something doctors are thinking about or the patients are thinking about, it's sort of a lower down on the list of priorities. And if something is lower on the list of priorities, chances are it's not going to be talked about at a given visit or over a whole series of visits. So these things can kind of linger and linger. And so the idea for the brochure really came out of the concept that let's try to take it away from relying on the doctor to proactively discuss that with an older person or their sort of care partner when they come in. Let's help those older people and their care partners themselves have that activation and that empowerment to get the information directly without having to wait for the doctor to raise it up, to learn more about their medications, to learn more about the problems that they might be causing them, and then to raise that concern, bring that to their doctor as opposed to waiting for the doctor or the other prescriber to sort of bring it to them. So the brochures have shown to be effective because they're able to sort of help to they have effective strategies for helping to provide people information, but also giving them the sense of control and interest and sense of empowerment to sort of speak up for themselves and raise those concerns where otherwise they either might not have known about them, or even if they had a concern, it just might not have made it to the top of their priority list and therefore never been discussed with their doctor.
There are so many of us that are on lots of medication throughout our lives, and we may not be aware of when they've stopped helping us and when
Yeah.
they've started hurting us. And I think the value of the brochure is our own, taking our health into our own control. What really comes to my mind here is that in the geriatric space, individuals have a lot of different types of conditions, often chronic.
Yeah.
How do you, from a medical perspective, distinguish between medicines that are helping and hurting?
Yeah, it's not always easy. So Um, I sort of think of medicines as two broad types of medicines. And one type is medicines that are used to help control symptoms you're having right now. So, for example, if you're having heartburn symptoms and you're taking a heartburn medicine, are your symptoms getting better? Are you having less heartburn, less often attacks, less severe attacks? If you're having pain, say knee pain, and I give you a new medication or a new treatment, does that reduce your pain? So that's pretty straightforward. Then there's a second class of medications that are preventive medicines. These are medicines which don't help you feel better right now, but they're designed to prevent some bad thing from happening in the future. So a classic example of that is aspirin. Taking aspirin doesn't make you feel any better or worse the day you take it, but the goal is to prevent a heart attack or a stroke a year from now or 10 years from now. And the same is true of a lot of other medicines, cholesterol lowering medications, medications used to treat bone density, and the list goes on and on. So when I'm thinking about medicines that may no longer be helpful, if it's a medication used to treat symptoms, I'm looking at, well, how is the symptom? Does it seem to be better than when they started the medication? And maybe if it's not better, or they're having what I perceive to be side effects of those medications that are worse than the thing it's trying to treat, that's a target. And then in terms of the preventive medicines, if someone's taking a preventive medicine, but their risk of actually having that future event is really low, so there's not much to prevent, then you have all the potential adverse effects of that medication with relatively little benefit. And there might be other times when someone's got so many other things going on that it's sort of lower on the priority list, and it's important to sort of think about reducing the emphasis on that condition and making sure that we're emphasizing the other conditions that are more directly impactful on a person's health and well-being and consistent with their goals. So it's integrating all of those things together. But as you can imagine, it's not always a simple just like checkbox. It takes some time and conversation and thinking. And that's part of what makes deep prescribing difficult because it takes time.
For our listeners, what guidance do you have for them in terms of kind of how they can bring deep prescribing into the conversations as they're working with their geriatricians or as they're conversing with different types of providers? You know, we have listeners who may have kidney challenges and heart challenges and may have
Yeah.
medication that negatively impacts one part of the body, positively impacts another. Kind of
Yeah.
how do they navigate those kinds of decisions?
Yeah. No, this is a great question. And I guess I would have a few recommendations for people. The first is just to understand what medicines you're actually taking and what they're for. Because a lot of people are taking medicines, but they're not really clear why they're taking it. And to be truthful, a lot of times the doctors might not know why you're taking it because someone might have been prescribed a medication 10 years ago. You suddenly get a new doctor, and that new doctor continues refilling that medication every year isn't really fully sure why the person's taking it, but figured, well, someone prescribed it at some point. They must have a reason, even though that reason may have gone away, 10 years ago. So it's understanding, what your own medications are for. And then if you say like, hey, I'm taking this medication, but I don't really know why you've looked into it and you're like, why am I taking this drug? Or you're taking a medication and you're thinking like, well, is this really still needed? Maybe I have this condition or this issue that the medication is trying to manage, but like, is this really important? And you have a question or a doubt in your mind. Those are great things in which to kind of raise that concern to your doctor. And it's not the sort of thing you want to say at the very end of the visit when your hand is on the doorknob, kind of on your way out, because then it's too late because these conversations take time. So it can be useful just to raise that early in a visit when you go in to see your doctor or nurse practitioner or other prescriber. Like when you sit down in that chair or in that video visit and you start the visit, it's like, hey, these are the things I want to talk about today. And one of these things I want to talk about is about my medications and sort of putting that front and center as part of the conversation. And maybe you don't have a chance to get to it during that first visit because there's something more pressing that you need to deal with. There's not enough time. But then maybe it makes sense to make another visit, schedule another visit a month later or 3 months later, in which your agenda for that visit is to discuss your medications. So kind of raising it front and center and making sure that you're communicating to your prescriber that you want to take the time to discuss these things, to review your medicines, to determine if they're all still helpful, and to go over potential side effects and see if you might be having those side effects is really like probably the most important thing of all.
What could be interesting for us all to wrestle with and to come up with a recommendation here too is what kinds of conversations with our healthcare professionals are best in various venues. So as you're just talking about this live and you're saying, look, you should have this conversation with your doctor in an appointment about deep prescription, I can now email my care team or, write a note to them. And I wonder what your perspective is on like having different types of conversations, online with a care team versus, in person, and also how to have those conversations with various people involved. Because particularly, I can imagine being 80 and maybe wanting someone else to be there with me if I have the conversation, or trying to give access to someone online. So if
Yeah.
you can talk about maybe how to navigate different types of conversations with technology and why this one might be one to even take online, that could be very helpful.
Yeah, that's a really important topic that you're raising. The way I think about it is that like electronic communication, like sending an email or a message to your care team is good for very sort of simple, discrete questions where you don't require much back and forth conversation. It's just like communicating a fact. So like I'm having this symptom, do I need to make a visit? Yes or no? Or like I'm taking, I was looking at my medicine cabinet, I saw this medicine, and I'm not sure whether I'm supposed to be taking it. Am I supposed to be taking it or not? And then that's not a venue for like the doctor having a thorough conversation about the risks and benefits of that drug. They basically give them a chance to look at the medication list that they have access to and say, yeah, yeah, that's on your medication list. You should be taking it. And no, I've never heard of that medicine before. Like, don't take that. That's a mistake. So that's good for that kind of conversation. But if you're having like, well, I'm worried about the on potential side effects of my medications, or if this medication is still really necessary, that tends to involve more of a conversation, because then you need to sort of say like, well, what side effects are you having? And then the doctor maybe just needs to do an assessment of whether those side effects they think are actually due to that medication or due to something else. Or if, say you're taking a medicine and then the question is, do I need this medicine anymore? Sometimes the answer is, very cut and dry. But other times it's more just like, well, we need to review your history. We need to review your current status. We need to look at the context of the other medications. And that becomes more of an involved process. And so that's not good for just a quick message to your provider. So for these more things where you're really reviewing over the longer term, what is the right medication regimen for you, and sort of having these more in-depth conversations, I would not do that electronically, because it's frankly probably not going to work so well. But that is a great thing to do in a visit, and that visit can be in person, or that visit can be in video, and it can be over the phone. And if you're an older adult, having your kind of care partner, your adult children or other caretaker be there can be super helpful, because for several reasons. One of the reasons is during a typical visit with a doctor, a lot of information is going back and forth, and it can be easy to get overwhelmed. So having another set of eyes and ears there, just as a way of like, hearing what the clinician is recommending, can be super useful. So after the visit, you're like, what did that person say? And then you have someone else who can kind of help remind you or remember. The other part, and I find this very useful, is that, it can be useful to have more than one person sort of giving a perspective on how someone is doing. So say, for example, I'm going to visit to talk about my knee pain, and say I'm an older adult. I might go and say, oh, it's not really my knee pain. It's not that bad. It bothers me some, but then if there's like maybe a spouse or a adult child or a caregiver in the room, and they say, well, actually, I've noticed that every time you try to climb the stairs, you're wincing. And actually, you've stopped really going out for walks like you used to, because it hurts too much, and so that gives the clinician a lot more information and a different perspective about what's going on with that symptom and how it's affecting your daily life. So having and it's not that it's contradicting the first person, but it's just providing additional context. So for that reason, I always encourage, people I see to kind of have someone else join that visit, whether it's in person or on the phone or on video, or sometimes if it's an in-person visit, but that caregiver can't be there, just dial them up on speakerphone, just make sure they're available, and having them engaged in that visit can be really helpful.
I think what I just heard you say is it's actually helpful oftentimes for a clinician to have multiple people in the room. It's actually helpful for the clinician as well to have multiple people in the room. Is that right? Is that what you said?
Oh, yeah, 100%.
So what's interesting is that we lie to ourselves and we lie to each other.
Yeah.
And it hurts to say that out loud a little bit, but it's also something that we have to navigate together. Like if I want to bring someone into my hospital visits with my clinician, whoever I am, then I've got to get to the truth with that person first a little bit, because something might be coming up with my doctor that's more private.
Okay.
And so I also think that's a really important part of this conversation too, around, look, everyone benefits with a little bit more transparency to get to better outcomes. And in order to get there, we've got to figure out who to be transparent with to be able to bounce these ideas off each other to get to these better outcomes. And I hadn't really thought about that before, but there's like a step before being transparent in the doctor's office, because if I come to you with someone, this would never happen to me, of course, it would never happen to me, but if I was coming to the doctor's office with someone and suddenly everyone was surprised by information that came out in the doctor's office, we have to deal with that surprise.
I think what you've hit on is something that's important. there's a danger about taking it too far. So transparency is really helpful, but sometimes, I mean, older adults are adults, and we all want our privacy to a certain extent, and we don't want people butting in our business. And so there's a balance between, having being open and transparent versus being sort of perceived to be intrusive or butting up against someone's autonomy or privacy. And so say, for example, you're a adult child and you're working with an older parent, and that older parent doesn't want to really tell you that much about what's going on with their life. I mean, it's useful to have their transparency. I would encourage it, but like ultimately it's up to them. And if they really feel like they either want to protect the adult child or they just feel like it's just my business and I don't want you butting in, like that's ultimately their right. And if that's the most important goal for them, if it's more important for them to maintain that sense of autonomy and privacy, and that's more important to them than say their knee pain or that they're feeling like they're slowing down. Um, that's okay. There's a balance, of course, to be had here. And we see this also sometimes with new technology about all these sensors you can install on homes, cameras and fall sensors and stuff like that. And those can be useful for someone who really wants it. But clearly there are some older adults who are like, I don't want to be bugged in my own home. I don't want like a whole bunch of cameras and sensors tracking my every mood and my children calling me 3 times a day to make sure I'm okay. So for some people that really works, but for other people it doesn't. And I think part of the conversation is being transparent about one's own limitations and challenges, but it's also just being transparent about what sort of um, monitoring and help you want to have and is helpful to have, and what feels like too much. And that can change over time. And sometimes engaging a clinician in that discussion can be helpful, but I wouldn't always presume that maximal engagement is always the right thing.
I think figuring out that balance and having that discourse is a meaningful thing to do if you're trying to get optimal health outcomes.
Exactly. And sometimes it's prioritizing. Like there might be 3 or 4 things which are troubling, but let's figure out the one that's like the most dangerous or concerning and focus on that one. And maybe if there's concerns about, maintaining autonomy or about sort of privacy, you can kind of, put your political capital in that one sort of area that's of greatest concern. And the other 3, as long as they're not, causing imminent harm, you can just like, let that ride a little bit.
When it comes to medication management for your family or kind of
Yeah.
caring for them when they may be experiencing some kind of long-term disability, such as inability to swallow or perhaps some kind of memory loss, what's your
Yeah.
best guidance there in terms of navigating that personal relationship with your family member and their autonomy, but also your need to caregive for them?
Yeah, I mean, I think it becomes more difficult when people lose the ability to make decisions about their own health in sort of a way that is sort of thoughtful and consistent with their goals, which is, what happens, unfortunately, is dementia. It can sometimes progress. So sometimes if someone is having cognitive impairment and they might be resisting help, but they really do not have sort of the mental wherewithal to articulate why that is, or to really be frankly safe, helping to manage their own health. Then at that point, a more aggressive posture can be helpful. Again, it's a balance. But and sometimes engaging with their clinical care team, having that group visit with the doctor, and sometimes it can be useful to have the doctor, the nurse practitioner, or the nurse be the one who really says, like, you know what, you really need to let, that care partner help out more here. You really need to allow them in. But and that can save the interpersonal strain within the family by sort of offloading that being the bad guy to someone on the care team.
And when it comes to the concept of deprescribing here, can you walk us through a little bit about how that's particularly helpful, if it is, for, the senior population, given how many medications they may be taking and maybe their resistance to taking that medication to begin with?
Yeah, exactly. So in terms of like thinking about approaches to deprescribing, like I had mentioned earlier, sort of the first step is for the really important step is for people to understand what they're actually taking and why they're taking those medicines and to raise it with their doctor. But once that sort of conversation starts, some of the important things to think about is for reviewing each of these medicines in a systematic barrier and basically asking two questions. Is this drug needed? Is it causing more harm than good?
Mm.
Right? And so the needed is like, is there a reason you're taking the drug? Maybe you're taking the drug for something that was prescribed 10 years ago and that reason has gone away. So that's easy. Then the second part is like the benefit and harm balance. And typically that has to happen as part of a conversation. I would discourage people from making that assessment themselves because they might think, oh, I don't need to take, or, you might be reading about a medication. You're saying, well, this medication is used to treat this disease. Well, I don't have that disease, so I don't need this medicine. You stop the medicine without talking to your doctor. Or like, I'm having this symptom, and I think this symptom, I'm having nausea, I'm having dizziness, I'm having diarrhea, something else. I think the symptom is due to this medication, so I'm just going to stop the medication. I would recommend against that because it might be prescribed for a reason that you don't know about. But if you talk to your prescriber, they could maybe help to educate you and why it's important to take that medicine. And also, a lot of things can cause dizziness and nausea and diarrhea and feeling off and, et cetera, et cetera. It might be the medicines, it might be something else. And so rather than sort of diagnosing yourself, it can be really important to go to your care team and say, like, hey, I'm having this symptom. Could this be a side effect of the medication? And then having that be part of a conversation. So I'd recommend against people trying to make these decisions in isolation. Always talk to your doctor if you're thinking about stopping a medication. But that said, there's oftentimes a lot of medicines when I'm going through someone's medication list that really aren't needed or can be stopped. Just because medicines they're sticky. You get something once and it just tends to stay there forever, even if it's no longer needed. Um, and so there's oftentimes, if you take that process of actually reviewing the medications, actually saying, what is this drug being used for? What are the benefits and the harms? There's typically a lot of stuff that can be stopped. One of the other challenges that can sometimes arise is maybe you got one medicine from your heart doctor and one medicine from your stomach doctor and one medicine from your kidney doctor. And you go to see your primary care doctor. They're like, I don't know. I think you don't need this medicine anymore, but I want to defer that decision to the heart doctor. So that can also make it difficult to have this process of deprescribing. So in that case, it can be useful to go back to your heart doctor and say, like, do I need this medicine? And it might require, it's not going to happen all at once, but over a period of time, talking to your doctors. The other thing you can just say if you're going to your primary care doctor, you say, I don't know if this medicine is needed, I defer to the cardiologist. Well, you might say to the doctor, well, can you ask the cardiologist, send them a note?
To that point, Dr. Steinman, and sorry to interrupt,
Yeah.
it would, in your view, is it appropriate to ask my primary care doctor to check in with my cardiologist? And the reason I ask that is because we're often encouraged to do some of that legwork ourselves as patients. But in my view, like my general practitioner should have more information than me generally and know the health context better than I do. So what could you point us in a direction on that? Like, should we take that on ourselves or should we ask our PCP to do that on our behalf?
Like everything, it's a balance. And I think it's very context dependent. So I think there's
Okay.
some situations in which it's always good to be empowered yourself, right? So the more that you can, as the patient or the caregiver of an older person, you are the one who has the greatest investment in your health, and you're the one who's the most attentive to it. Because your doctor is going to, after they see you, they're going to go on and see a whole bunch of other people, but you are you, and so you're the only one who's actually going around and seeing your other doctors. You're the only one who's putting those pills in your mouth. So you are the person who's been most directly affected. Plus, you also know the most because you know actually what you were doing, and you know what that cardiologist said and the kidney doctor said because you were there in the room with them. So don't discount your own agency and having these conversations and making that happen. That said, when you're going to talk to, say, your primary care doctor, I would maybe ask the question. There are some situations in which that primary care doctor can say, oh, yeah, I'll shoot a note over to that person, no problem. But I'll tell you, there are other situations where where logistically, even though we would want there to be easy communication, there just isn't. Like, and I'll just anecdotally, I'll share, a lot of doctors are not, if they're not working in the same health system, they may not be connected electronically. Believe it or not, we still oftentimes rely on faxes to send information. We don't really have email addresses for people who are outside of our network or secure means of communication. In some cases, yes, in some cases, no. But you imagine how busy doctors are, and then you're kind of, just anecdotally, as the doctor, I'll call the doctor's office. I'll be on hold. I'm waiting. I'll speak to to the front desk. They'll try to get the doctor, and suddenly 10, 15, 20 minutes have gone by. And then I've got other people in my waiting room right now, like banging at my door saying, "Why aren't you seeing me? You're running late." So these things take time. So some of these conversations can happen quickly. Some of them are probably beyond the scope of your primary care doctor to be able to handle just because of the way our health system is designed and the logistical challenges. So that's just another great question to ask the primary care doctor. Is this something you can do, or do you need me to do it? So talking to your pharmacist can be super helpful. They're experts in medications, right? So if you have a question about your medication, do I need this drug? What's this drug for? I'm having this symptom. Could it be a side effect? Trying to sort of talk with a pharmacist, whether it be your pharmacist in your local retail pharmacy. A lot of health systems have pharmacists, and you can ask to talk to them, can be extremely helpful. And other members of the healthcare team, nurses, other folks, they might have different amounts of information, but it always is helpful just to ask, and try to get as many perspectives and people involved as possible. And then, of course, taking your own health into your own hands, and looking up information about your own medication, so you're an informed consumer or an informed caregiver, is super important.
When it comes to navigating the conversations between different specialists, so for example, say you have a challenge with your kidney, you're receiving medication for that, and it might be negatively impacting a heart condition that you already have. Given that these are isolated conversations that you're having with these specialists, how do you suggest a patient kind of navigate that specific balance there?
Yeah. I mean, it can be really hard when, say, like, I don't think this happens that much, but it can happen. We say the heart doctor is saying you should take this medicine, the kidney doctor is saying you should not take that medicine, and like, who do you believe, right? That's pretty rare in my experience. By far, the more common thing is like the heart doctor sort of thinks you should be taking the medicine, but maybe it's a little discretionary. And the kidney doctor thinks that it's probably not the right thing, but they sort of want to defer to the heart doctor, and it's not like a huge problem. Sort of that middle ground. Um, but the problem is like, and honestly, if the heart doctor and the kidney doctor just had a chance to talk together for 2 minutes, they could probably sort it out. But they don't, because they're busy and they might be in different health systems, and that kidney doctor has to talk to 35 other doctors. So it's probably not going to happen unless you, as the patient or the care partner of that patient, raises it. And you say to the cardiologist, in that case, who you're going to see, hey, like, I heard from a kidney doctor, and I'm not so thrilled about this medication, or I have a question, like, could you talk to that kidney doctor? Like, let me put you two in touch, or they're telling me this and you're telling me this. Can you please help me sort it out? And just actually elevating that conversation where you're asking for that help and reporting on the discrepancy.
I think that's key, because there's this unspoken power dynamic too, right? Like, giving people permission to ask their doctors to be in touch and like push that envelope a little bit. Going back to deprescription was a little scary to me because it had a context of palliative care. And I don't think that's true anymore. And so I would love for you to talk about that, just to move that myth a little out. And the reason that I say that is because often when people go into hospice care, there's these conversations around like, how can we make you comfortable? But even then, it could involve prescribing something, not just
Yeah.
deprescribing something.
Yeah, no, I'm glad you raised it, because there is sometimes that perception when you're taking something away, you're reducing or stopping a medication means you're giving up on someone, or means that you don't think they're going to live as long, or you don't think that they're valued or important. Like, there are these sort of subtexts and impressions that people get, and that is sort of far from the truth. And so in a way, like, deprescribing isn't probably the best term, even though we use it a lot. Well, I'd like to think about it, you're just personalizing or optimizing care. So you are you. You have your own set of conditions, you have your own set of goals and things that are important to you. And then the medications are tools to help you achieve those goals based on who you are and what health problems you have. And it's the Goldilocks rule, right? It's finding the right balance. It's neither too much or too little, but finding that right balance of things that are right for you. And consistent with what health conditions you have, your willingness to take medications, your ability to take certain medications. Maybe if you have swallowing difficulties, trying to avoid big pills is a good thing. If you have visual difficulties or cognitive difficulties and you're trying to take insulin and there's nowhere to help you, it's probably a bad thing because the risk of overdosing is really serious and going to get into serious problems. So it's finding the balance of all those things. And so deprescribing is just one part of good prescribing where you're just trying to find out how can I best help you, live the fullest life you want. And sometimes that involves adding medicine, sometimes it involves taking away, and more often than not, it involves both. But the most important thing is that, like I said, deprescribing, it's not taking away. It's finding the balance that is most helpful for you.
I love that. It's more like every one of these conversations is a point in time. Like, don't think about it from a perspective of loss, right? You're gaining better outcomes every time there's a rebalancing. It's
Right.
kind of like for people who, do financial investing, we want to rebalance your stock portfolio. What does that look like? We just need to rebalance these prescriptions, right? That's what we're trying to do to get to the best possible outcomes here. Can you, talk about maybe an anonymous story or like a case that maybe you'd teach, some kids about in school as they're going through residency or whatever about like, look, these are the kinds of things that we're practically looking at and the outcomes that we can achieve with them.
Sure. I mean, I'll just maybe give a few examples. So one example is one of the things that commonly comes up with over medication and people end up with two medications is these things called clinical practice guidelines, which are basically, very well intentioned and often very helpful professional guidance that says if you have this disease, you should be on these medications. So for example, if you have high blood pressure, you should be on this medication and that medication until your blood pressure falls below a certain number. Or if you have heart failure or a certain heart condition, a certain kind of heart failure, you should be on, medicine A, B, C, D, and E. Um, and that we're just all taught that that's the way we should practice. But then I've had people come to me and say, well, I'm getting all these medicines and you know what? Every time I stand up, I feel so lightheaded. I feel like I'm about to fall over. It's like, that's not good. It's not good for your health. It's not good for your quality of life. Like, and that is not what these guidelines intended. So in
And that's
that case,
amazing. Just standing up, right, can have that much of a difference. Just the blood pressure change and just sitting down
yeah,
and
it can be
standing up.
huge. And some people tolerate these medicines totally fine, right? And some people do not and have a hard time tolerating them. And it's often very hard to know at the time I'm prescribing these medicines which camp someone's going to fall into. So sometimes the best thing is you try these medicines, you start them, and then see how someone does. And so part of it is once you start a new medication, you follow up with them and you say, like, hey, you just started this new medicine. Like, are you feeling lightheaded? Are you feeling dizzy? Are you having stomach pain? Things like that. And just proactively assessing for side effects. But a lot of times that just in reality doesn't happen. So some success stories is I've said, well, you're taking all these medicines. They are, they are recommended by guidelines, but the guidelines do not intend to give medicines to people that are causing them active harm. So let's just like stop the medicine. It's sort of a no-brainer, but it sort of goes against the way we've been trained. And you'll still get these alerts on your screen as the doctor. Why isn't your patient, they have heart failure. Why aren't they taking this medication? It's like, well, because that medication, every time they took it, it made them pass out, but like the alert doesn't know that. So there's this pressure to always prescribing. So part of the deprescribing sort of ethos is like, let's take the big picture in mind. And so for like patients like that who I've taken care of, sometimes just like using that common sense approach and saying like, look, we tried these medicines, they're causing more harm than good. Like no one wants you to pass out or feel like you're about to pass out every time you stand up. Like, let's stop that medicine. And those people feel better. And that is not only good medicine in general, but it actually meets the goal. The problem is the reality is a lot of times, even relatively basic stuff like that doesn't happen. And it's not because doctors are bad people and it's not because they don't care. It's just because we're busy and we are incentivized in certain ways and we're focused. And during a clinic visit, a lot of other stuff might come up, but you might saying you're feeling lightheaded and we're trained to think of, is there a new diagnosis that's causing that, as opposed to thinking, could it be a side effect of the medication? So we might even miss that symptom's due to medication side effect. So there's all this swirl of stuff that can kind of get in the way of identifying side effects as being due to medications and stopping them. So part of them, so that's been some of my success stories about being able to kind of break that illogical chain and just realizing sort of the common sense thing. But a big part of it has also been due to my patients helping me by saying, hey, I'm having this symptom. So I know about it, because a lot of people are having symptoms, but they maybe don't tell me about it. And then also asking, hey, could this be a side effect of this medication? Because that really helps me as the doctor to think about it.
You mentioned that deprescribing is a relatively new concept in the
Yeah.
medical. And given how doctors are incentivized right now, how is it being received by your peers? Is it something that, if we were to go to our doctor and ask them to do this audit, it would be well received?
Yes. I mean, I think there's a lot of enthusiasm. A lot of doctors realize that, there's this paradox, right? Where like many people, particularly older adults who have a lot of chronic health issues they're dealing with, they're taking a lot of meds. There are few people who like taking a lot of meds. So it's very common to feel like, oh, I'm taking so many meds. You just hear that all the time. But then actually figure out which one to stop. Like, should we stop this one? No, I can't stop that one. Should we stop this one? No, I can't stop that one. And then so like there's not a solution to fixing that problem. So, but doctors, I think, very receptive to the idea of people are oftentimes taking meds they don't really need, and they're open to stopping and reducing medications. I think the things that really help doctors to succeed in that mission is to make sure that there is enough time in the visit to address it. So it's not the fifth item on the list where you've now gone through the first four items and you're already running over your time, and then you introduce a new thing. So making sure it's mentioned at the top of the visit, and so the visit might have to be dedicated solely to that topic, because that might be the only thing there's time for in that visit. And you can make another visit to discuss the other stuff. So that's one thing, making sure there's adequate time. And then the second thing, having patients and their care partners really come sort of to be an informed and active part of that discussion. Because some of the problem might be, well, I see you're taking this medicine, you're having the symptom, maybe it's due to that medication, maybe we should stop it. And then the person's like, well, am I taking that medicine? I'm not sure. And then it really kind of complicates things. Or you might say you recommend stopping a medication, and the person goes home and they don't really track on the instruction, or they're not sure, well, you told me to stop the medicine, but is it the pink pill or the blue pill? And then it never ends up happening. So it can be really helpful to clinicians in that conversation, for patients and care partners to come and sort of be an active part, to know your medicines, know what you're taking, and be part of that conversation in an active and informed way.
It sounds like the prep work for a deprescribing conversation then has a couple parts to it. One would be setting up the appointment such that the doctor knows in advance that that's the primary reason for the appointment. And it sounds like I should come prepared with all of what I'm taking. Like, here's what I'm taking, here's what I'm on. And it also sounds like I should come with a genuine assessment of my symptoms. And if I come with what I'm taking, and I'm coming with like who I am and how I am every day, from like is this a symptom? Is this a pain? Is this like a dizziness? Like, is this a coldness or a numbness? Whatever those symptoms are.
Yeah.
If I've prepped my doctor to know what to expect, if I come with what I'm taking and I come with my symptoms, it sounds like I might be able to have a really fruitful rebalancing conversation around my drug regimen.
Yeah, no, that's absolutely right. And I think that, so having that sort of holistic conversation, reviewing all of your medicines, is super helpful in all the ways that you just mentioned. I don't want to sort of distract from the fact that you can have these conversations in smaller forms in other ways. So for example, it might be hard during a visit where you're consumed with other topics to review the entirety of the medication regimen. But say you're there talking about your heart condition, and you have a question about one specific medication, it's certainly reasonable to ask, like, hey, we're talking about my heart. I'm taking this medication for my heart. Like, do I really need this specific medication? And that can typically be a shorter visit, because then you're dealing with one medication, not with 15 different medications. So it shouldn't dissuade people from raising this throughout the course of over a series of visits. But if you really want to go through the entirety of your medication regimen, which is a good idea to do every year or so, then having that separate visit where you're doing that is also helpful.
It does sound then like something that you would encourage people to consider is a holistic conversation annually, right?
Mhm.
Have a holistic conversation annually.
Yep.
Um, and then something that, we talked about at this beginning, this concept of a brochure being an intervention, not like a prescription. Should we expect, as we have these conversations for ourselves and with people that we care about, different types of interventions with our doctor now?
Well, I think maybe we're trained as people having grown up in sort of modern society, think that like if we're having a symptom, we have a disease, the cure is a pill or medicine of some sort. That's sometimes true. It's often true, but many times it isn't. And many times, like pain is a great example. A lot of times, pain medicines aren't so helpful and can have really substantial side effects. Sometimes they're really helpful. Doesn't mean there's not a role for them, but a lot of times, honestly, like people with joint pain, hip pain, knee pain, shoulder pain, if I can have that person get set up with a physical therapist, uh, that is often far more beneficial to them than any medication I can prescribe them. Or other therapies, hot and cold packs, rub-on medications. For some people, acupuncture or massage can be really helpful. And it's not to say that medications don't have a role. Of course, they have a role. But there's a lot of things that people can do that do not involve putting a pill in your mouth that can actually be both safer and actually more effective.
I think that really stands out to me in terms of the kind of guidance that I've heard for seniors in general. I think there's a lack of focus in terms of just how much difference getting outside, socializing, living an active, healthy lifestyle can do on just your mental well-being and also on your physical well-being. I think at least socially, we are conditioned to think it's all medical, and I really agree with you. I don't think it is. And I want to thank you very much for joining us today. Is there any last thoughts you want to share with our audience as we wrap up here? What's top of mind from a geriatric perspective that caregivers should keep in mind?
Just be an active partner in your health. Like your doctor doesn't have all the answers and they can't read your mind. And they have their own limitations. We're busy. And so being as active and engaged and not having all the answers yourself, but making sure that you're able to be part of that conversation in a meaningful way and elevating and raising the things that are important to you and on your mind and having the knowledge about your own medications and health status that can inform that conversation is probably the most important thing of all.
What might you encourage someone to take 60 seconds today to do to be good to their future selves?
Number one, exercise. Number two, make friends and be social. Number three, eat well. Those are most important. And then in terms of the medications, specifically on this topic, I would say just, talk to your healthcare team every once in a while about your medicines to make sure that they're the right ones for you and you still need them. These things tend to add up and add up and add up over time. So if you can break that cycle by every once in a while going through and saying, do I still need this medicine? You can take them away before they have a chance to kind of, stick on you forever. That can really maybe help to reduce the burden of these things as they accrue over time.
Fantastic. Thank
Great.
you.
Sure thing.
Thank you so much.
Yeah, thank you so much.
Sure thing. All right. Bye-bye.
Right. Well, Ashwini, now that it's just the two of us, let's have a moment to chat about what we just learned.
I thought that was very interesting.
I love that. I think there are a few things that I took away from that are really compelling. One is the steps that Dr. Steinman outlined, which is figure out what you're on. First, make sure you know what you're on. So you have to do some of that reconciliation yourself. Only you know what you're actually taking. Figure out what your symptoms are, and then talk to a doctor every year or so. And that seems like a pretty reasonable thing to do that could lead to really positive outcomes. And I also thought he said this idea of like deprescribing, if it's catching on, is probably a term that isn't the best term, and maybe from a marketing perspective could be thought of as like optimizing care instead, and to like do this rebalance or optimization instead of doing a deprescription. I think we all struggle with like framing things, and that could be really useful. Even in going to our doctors, I would like for my care to be optimized this year? What would that look like?
I
And then
mean,
pharmacists
even-
too. Like that was a great call out, leverage the whole care team.
I mean, also imagine being a pharmacist packing all of those drugs that people don't even really need or should not even really be taking. Imagine the amount of time they could save if they just were like only giving medication that people actually needed to take. I think there's also the question of how many medications are we taking day to day that are actually making us feel sick, that are preventing us from going out, preventing us from eating well, if it's making you nauseous, if you can't stand up to go on your walk, if it's making you dizzy, it might increase the likelihood of a fall. There are lots of reasons why, we as individuals should be doing that spring cleaning of all the medications we're taking to make sure that we're preventing these kinds of negative outcomes as well. I
That's
mean,
the
think
reality.
about it this way, we are the common denominator in our care, right? Who is the one person who is in every single room? It's you for the most part. So you are the wealth of knowledge. You being the patient is the wealth of knowledge in this specific case. So, and you're the one who benefits the most from accurate care, right? So making sure that you are well versed in what you are being prescribed and also the treatments that you're being prescribed, making sure you're staying diligent with them, but also advocating for yourself is something that really stood out to me in this conversation.
Um,
One other thing that also stood out to me was the nuances of kind of trust between families, and who you bring into that space. I think that was a very apt observation that you made actually during our episode. I think it is very vulnerable to bring someone into these kinds of conversations when you are not feeling well. Especially from the older individuals that we've spoken to, everyone has nuanced relationships with their family, especially as they're getting older, they want to maintain their independence, but they might also need support from their children and from their family and loved ones. And I think people need to not feel alone in that. There are so many people that we've spoken to are experiencing that exact dilemma. I think being intentional about who you invite into that space and making sure that they are trustworthy and recognize your autonomy and decision making in this space, but are there as support is crucial. So as caregivers and family, it's our responsibility to make sure that our loved ones feel safe to have us in those spaces and know that we won't overstep our boundaries if we can try our best not to do that.
yeah, I think his ability to make sure he advocated for autonomy and privacy for each patient also is critical. I think he did that so well. We shouldn't diagnose ourselves. We should come with symptoms. I think that's such a critical point too.
Yeah.
Like I love that when he was
Oh my
just,
gosh, I'm such a
I love this moment.
hypochondriac. I
Yeah,
always say that I have something that I don't have.
I know. I think this moment is so important in this podcast around like don't diagnose yourself. Like come with symptoms and come with like your drugs and all the things that you're taking, but do not let us, let the team that is supporting you have that conversation, but don't diagnose yourself. I thought that was, that's such a great such a great point because the internet can diagnose us so wrong, right? It's just like, oh my god, I've got all these other things that I'm looking through, and oh man, love it.
Even when we did our exercise going through our medical records, like you had medication on there that you were not actively taking. I have medication on mine that I'm not actively taking, but it still says active. And if I wanted to go get that medication filled, I could. And my doctor has no idea what I'm actively taking and what I'm not. Obviously, I'm not taking an enormous number of medication. I can tell them what I'm taking and what I'm not without the need for a brochure or something. But if I got older and, was maybe had like 5 or 10 more conditions that I'm being medicated for, that would get overwhelming, especially if I'm just on the older side and my memory is already deteriorating and I'm already overwhelmed with other things. So I
Yeah,
think
totally. I think one thing that our listeners can do is actually try to log in to your healthcare record. And if you haven't spent time doing that, it's worthwhile doing to understand whether or not it's easy, whether or not it's hard, and to also understand that some of the people we care most about in our lives are managing their health on a part or full-time basis. So that's something that they have a lot of experience doing. And for you to be able to engage in a conversation with them about whether or not it's tedious or whether or not it's easy, where information is coming from, just go through it yourself. And I think that just trying to get yourself informed about what what you're seeing and what other people see, I think that's a first step.
I'd actually love it if when you all do that, if you have any observations that you're willing to share with us about what that experience was like or what has stood out to you from what you've discovered, email us at podcast@palmistay.com. Erin and I have all kinds of opinions from our experience doing this and trying to piece together our medical histories. So I'd love to hear what your perspectives are, or if you have any examples of experiences where, your family members or even you yourself have found out that you're on medication you don't need to be on. Erin and I are we love to hear these stories. So we'll be waiting with bated breath for those emails.
Yeah. We'd love to hear from you off the record, not recorded.
Everything will be anonymous. We won't share anything with our information.
That's right.
We are personally very curious to hear more from you.
When Ashwini and I did this, we pulled up my health history on a big screen too the first time. I just hadn't seen it. And I was like, well, we're going to go through this together. And that was it was eye-opening.
Screen shared kp.org and went
yeah.
through.
Yeah, it was wild. I don't recommend other people do that, but as Ashwini and I are working closely together, we took that jump and learned a lot about me that day and how health information is managed online. So genuinely encourage you to do that for yourself and share what you learn if it's appropriate.
Thank you for joining the Palmistay podcast today with gerontology expert and medical doctor, Dr. Michael Steinman. Please remember that all of the information provided in this podcast is informational only. Medical advice is at the purview of your medical professionals, so please consult them to make sure you're getting optimal care. To make sure you don't miss our next conversation, please be sure to subscribe. You can also visit our website at palmistay.com for more insights and resources on the topics we've covered today. Share the podcast on social media. We are on x.com, of course, but also be sure to include it in any kind of iMessage or WhatsApp groups you're a part of. It's a great way for others to discover this content and have valuable conversations with their family members. Take care, and we will see you next time.